your teams as well. So we are recording, and welcome everybody to our webinar for today, which is Continence is Not a Dirty Word. I would like to introduce you to Gaby Brodbeck, who is today's guest speaker. I'm very lucky to have known Gaby for many years now and worked with her in many different settings. Gaby is a very experienced registered nurse. She's an aged care consultant. She's worked as an aged care assessor, and she still works clinically. So she's very much across what is happening out in the world of caring for older people. For those who don't know me, my name is Kathy. I am one of the directors at Thrive Aged Care Consultants, and up in the corner giving a wave is Kate, our co-director here. We love running these lunch and learn sessions once a month now, and sometimes a little bit more frequently, to provide you with some free education on hot topics in the areas of supporting older people. So thank you for coming along today. We hope that you all thrive after this session and that you get a lot of takeaway information from Gaby about continence. Just some quick housekeeping. This session is recorded and you will receive the link and the slides after the session. We will keep questions until the end, but if something is burning and you want to bring it up, please do use the chat function. But given we're expecting quite a number of people, we keep questions until the end. Otherwise, we lose the whole half an hour. So thank you, everyone. And I'll hand over to you, Gaby.
Thank you, Kathy, for that very kind introduction. Welcome to you all. Thank you for attending today. I'm hoping you'll get something out of today and be able to take it back to your workplace. Continence is not a dirty word. It certainly isn't. It's certainly been a passion of mine for the last 25 years. And when I started in aged care, we were doing rounds and all the bad habits you can imagine. So I've got a lot of lived experience that I can share with you and certainly show you some improvements that you can all do. So basically today, what we're going to talk about is the healthy bladder versus what happens to the bladder as we age. The main different types of urinary incontinence, my experience as an assessor and what I've seen when I go out to nursing homes and telltale signs of potential poor practice. Then we're going to look at all the things that we can do to help improve continence within the home care setting and also the aged care setting in nursing homes through screening, assessment and care planning. And last of all, we're going to follow up with some organisational take-home tips and also some staff take-home tips that you can use in your practice from day to day. So, I mean, look, a lot of you probably all know this, but the bladder is a muscular organ that is the shape of a large grapefruit. This is in the healthy bladder. The bladder muscles stretch and collapse depending on how full it is with urine. It sits in the pelvis and you feel, with a healthy bladder, you feel the urge to void when it's about 300 mils in your bladder. Generally speaking, we void between 4 to 8 times a day. Our bladder holds between 400 and 600 mils of urine. And generally speaking, not all, but people can wake up once or twice a night, usually twice a night over the ages of 65 years. And the fact is that we are alerted to the fact that we need to void so we can get up and go to the bathroom. So the bladder informs us when it's full and it gives us enough time to find a toilet and have a wee. Our bladders empty completely each time we void and they don't leak urine. The impact of the aging bladder. As we age, our bladders become stiffer and smaller, allowing less urine capacity, which results in potentially us needing to go more often to the toilet. The bladder sensation and muscle contractibility is impaired, usually due to changes in our nerve endings. With men, prostate enlargement is a very common cause of urinary incontinence. So as men age, the prostate gland, which is about the size of a walnut and sits just below the bladder of the neck of the bladder, and it wraps around the urethra. This enlarges, which potentially starts to block off the urethra, which causes straining and poor urine flow and dribbling. Weakened pelvic floor muscles, well, that happens as we age, and it can also be due to pregnancy, childbirth, straining on the toilet for your bowels due to constipation, heavy lifting, high impact exercise such as weightlifting, jogging, and being overweight. So this all impacts on the pelvic floor muscles. Hormonal changes in females as we hit menopause. This will also, the decrease in estrogen will also affect the muscle wall in the bladder. Urinary tract infections can irritate the bladder, and this can cause irritability and give you strong urge to urinate. Anybody who's had a urinary tract infection will understand that feeling of that urge. It just suddenly comes on and away comes your urine. You have no time to find the toilet, and anybody who's had a UTI will be able to agree with that. And last of all, we don't go into it a lot today, but medication side effects. The main ones being antipsychotic, benzodiazepines, antidepressants can also impact on the bladder, causing urinary incontinence. Urinary incontinence is common and can range from an occasional leak when you laugh, cough, sneeze or exercise, to the complete inability to control your bladder. In many cases, urinary incontinence can be treated, better managed, and even cured. There are many different types of urinary incontinence, but we're going to focus on the four main ones. The first one is stress incontinence. Stress incontinence is the leaking of small amounts of urine during activities such as coughing, sneezing, laughing, walking, and lifting. Urge incontinence, which can also be known as the overactive bladder. This is an involuntary loss of urine associated with that urgency, that sudden, strong need to urinate. Functional incontinence, which is very common in the community and also in nursing homes. This occurs when the person's bladder or bowel is working normally, but they are unable to access the toilet, or they are unable to undo their belt and zip in time to get onto the toilet. And it's due to a physical or cognitive decline. Overflow incontinence is the frequent or constant dribbling of urine due to the bladder not emptying properly. And this can be due to nerve damage, blocking of the urethra, or again, side effects of medication. My experience as an aged care assessor going into probably over 50 to 60 facilities as an assessor, there were signs that I would see and smell, which would potentially indicate to me that continence is not being managed well. And some of these examples of that smell of urine when you walk into an aged care facility, I understand that you can have accidents, that, you know, these things do occur, but when you get that strong stench when you walk into a particular area of a nursing home, or just when you walk in the front door, this does not occur in good continence management, and it can indicate ineffective toileting program, especially early in the morning. As people are starting to get out of bed and people are being showered or getting sat up for breakfast is usually when it is particularly strong. And that usually indicates to me that perhaps overnight there could be some improvement in toileting, correct use of aids, etc. The use of Kylie's, chair covers or chair pads, blueies, as well as the use of continence aids. So often I would see people going to bed with continence aids on, and then they would have a bluey or a Kylie on top of the bed as well, on top of their bottom sheet. You don't need to double up. If your aid is the correct aid for you, it should be enough instead of having to use extra just in case. It's not required. That in turn is a huge saving in just the washing, having to pay for them, etc., etc. The language we use, nappies, pads, is not the correct terminology. That's a dignity issue surrounding that terminology. And words such as continence aid or product is really what is required to what you need to call them. Using of multiple continence aids, I've also seen this practice as well, where you'll have a continence aid on and then another slip aid inside it as well, just in case. Sometimes that is used for fecal incontinence to keep the larger aid clean, but generally speaking, it's not really used, and it's just an extra cost and it's uncomfortable. Another telltale sign for me as an assessor was when I started to look at the progress notes and the documentation. And like, for example, I don't think in my 25 years have I ever seen a 3-day bladder chart completed correctly. There's gaps, there's just, you know, just not enough information in the squares. And I understand it's a really difficult thing to try and keep a grasp on. But I've got some tips later on as to what you can do to help complete these this charting. And often too, when you look in the progress notes and you read, you know, so-and-so wet, so-and-so had full linen change of their bed, so-and-so had 3 changes of clothing today because they were wet. This indicates to me that your continence aid is not effective. The other thing is handover sheets and care plans, different toileting times on both of them. So I would ask, so which one would the staff follow, the care plan or the handover sheets? And sometimes too, where the continence aids are kept in a person's locker, they can have toileting times there as well. So you're looking at 3 different places. There's a high risk that the times are not going to match. So that's something to be very careful of as well. The rounds approach. Now, I used to be the queen of rounds. So it was basically me informing people of when they were going to the toilet. For example, after breakfast, before lunch, after lunch, before dinner, after dinner, on settling. They were my toileting times. They weren't evidence-based individual toileting times. And I think that's something that really needs to change, is to get away from that round meditation, around that round approach, because often with rounds, you'd sit people on the toilet and they wouldn't void anyway, because it wasn't their time to go to the toilet. Also, the environment is often not set up correctly. So, for example, signage, you know, pictures of the toilet, especially in memory care units. Also, good lighting at night for people who get up at night in their ensuite. Looking at rugs on the floors, a potential trip hazard as well. And also like large obstacles in the way of the door. It's just something to think about as you're walking around your facility or even in people's homes. Also, looking at increased falls overnight can often be an indication that people's toileting programs perhaps aren't effective overnight and they haven't been assessed correctly. Why is continence so important? Continence is so important because it's embarrassing. It affects people's self-esteem. It can actually be a cause of depression. There's a sense of shame about being incontinent. I mean, for example, if I locked all of you up in a room for 24 hours, locked the door, and there was no toilet, I'm guaranteeing you most of us would be incontinent. It just shows that anybody can be incontinent and that we are vulnerable to it. And I think when you have that understanding, it just helps you to look after and care for people with just another thought in mind. Continence is important because it does decrease falls if you have a good continence program. You just need to look at your audit results and look at the times and what people were doing at the time of their fall. It's often looking for the toilet or trying to find the toilet. Incontinence can increase the risk of infections and resulting in delirium, which is also something that we would like to decrease in aged care. And this idea that drinking less will mean that you void less is a fallacy. In fact, what it does is it makes the urine more concentrated in the bladder, which irritates the bladder, can result in more infections and also that urge incontinence. Continence is important because incontinence is associated with incontinence-associated dermatitis, which is painful. And when you've got it and you wee again, it's painful, it stings. So that's something that is a result of incontinence. And also, again, incontinence can cause increased risk of pressure injuries. And also people who are incontinent and aren't able to ask for the toilet or know where the toilet is, find it, have an increased risk of responsive behaviours, you know, that agitation, that wandering, the wandering into other people's rooms looking for the toilet, because for reasons like decreased cognition, they can't work out where the toilet is, and constantly reminding them that you've got a toilet in your room is not going to be effective in assisting them to find the toilet. And so they'll find the toilet in a flower pot or wherever. It's just so that they can void. Sorry, just jump onto the next slide. What's commonly missed too is the association of constipation and its impact on urinary incontinence. A full bowel can cause pressure on the bladder and the urethra, and it can increase urinary incontinence. And it's something that we don't tend to monitor very well in aged care, where we look at people's individualised patterns and determine when to give somebody a perience. Do we give them a perience day one that they haven't used their bowels? Again, this will really depend on the individual because everybody has their own pattern, and it can be quite normal for some people just to go 3 times a week to use their bowels. And also, constipation can be painful. It can impact on your appetite. Definitely, it can show responsive behaviours such as severe agitation, you know, even aggression. And as I said, it can exacerbate urinary incontinence. So bowel charting is incredibly important, as well as your 3-day bladder chart, to determine whether constipation can be impacting on people's incontinence. So the best thing we can do is to do a thorough assessment. And there's a couple of parts to the assessment process to determine a outcome for people. And it's great if you've got a multidisciplinary team and you can use OTs to assist with functional assessments and physios with mobility assessments to get a good idea as to how people need to be toileted, etc. So the first one that you will see in a lot of facilities is the continence screening form, which is really just a form to determine whether the person requires specialist referral or even whether they don't require further assessment. The 3-day bladder chart is incredibly important to determine somebody's individual pattern. Sometimes you can't get a pattern. We can't, you know, we're not going to get 100% strike rate here, but we can certainly make an impact on the majority of people. What I often see occurring, what needs to occur before a 3-day bladder chart is a urinalysis. No good doing a 3-day bladder chart if somebody has a urinary tract infection. That's very, very important because it'll skew the data. It'll skew how often they go, etc. So NAD analysis, and then the 3-day bladder chart. Again, if you can't get the 3-day bladder chart done consecutively, just do it on different days as long as you can get a 24-hour period across 3 days. The other thing that's really important is a 7-day bowel chart, and even extend it to 10 days or even a month, just to see if you can get a pattern, an individualised pattern for this person, and also to determine if they have constipation. And then a functional assessment to determine, you know, are they able to undo their trousers? Do they need to be changed into tracksuit pants because it's easy for them to pull them down, etc. So taking action. Don't collect information for the sake of it. It really needs to be looked at, analysed and summarised. The continence assessment is really more of a broad assessment, so to help put everything else together, to see if there are other things that may impact on them, such as dementia. And then we put all that information together to develop our continence care plan. And also, you know, a cognitive assessment to determine what level they actually can do for themselves, because at the end of the day, we really want to promote self-care. So a continence care plan, it's a plan of care to indicate toileting times, preferences, triggers that somebody might show before they want to use the toilet, and to ensure that there is consistent care done by all your care staff, so that I'm not coming in the afternoon, you know, taking somebody to the toilet at 3 o'clock when I come on, when it's clear that their toileting time, for example, isn't until 4:30. Evaluation is incredibly important. Whether you do, I don't know whatever it might be, whether it might be 3 monthly, 1 monthly, or again, looking at if the toileting times don't work, redo your 3-day bladder chart. If you notice that people are starting to use an increased number of aids, again, indicates that probably your current program is not effective because you shouldn't need to use more aids. So, for example, if all of a sudden the cost of your continence aids is increasing, you need to look at why this is happening. Because there's definitely an industry average of the amount you should be paying per day for your continence aids. If there's a change in an individual's physical or mental condition, this may impact on their continence care plan and the outcomes of their toileting program. So you might need to go back and reassess. Take-home tips for an organisation. Who completes your continence assessment? Are you utilising your registered staff? Often I see PCWs filling out continence assessments. I really don't think that they have the expertise or the knowledge base to be filling out a continence assessment. They can certainly help with the 3-day bladder chart. So I think it's important to use registered staff. Use a multidisciplinary approach to assist you through the assessments. Use your OTs if you have access to them, your physios. I think it's really important to speak with your personal care staff, because often they know intimate details about people's continence, but it's not, they don't pass it on. So you need to go and ask, because they really do know a lot. They often know the triggers to people's, whether they need to go to the bathroom or not. Think about a continence nurse role if you're in an aged care facility. Nobody really wants the role, but I think it's a really important role. They can oversee your assessment process. They can oversee the bladder charting for you, and help get your assessment completed. Do you have a continence program, training program for your staff? Is it mandatory? Personally, I think it should be mandatory. How many staff attend? Do RNs attend? I think it's really, even if you just do a toolbox talk and just talk about the importance of completing a bladder chart, because I know how frustrating it is when you come on in to your shift and, you know, for example, night duty hasn't filled out anything overnight, or the morning shift and there's gaps. So it's I think the use of the training program and just having short bursts of training is really, really important. When did you last review the provider that you're using and your continence aid ordering system? They're expensive, they're landfill, and I think it's something, if you can minimise the usage of them, I think it's a great thing to do. I found that the continence providers had exceptional education, and they will come in and do education. So book them in advance, because I know they are really busy. They do great sessions. They also do day sessions. So you could potentially get your continence nurse to attend a day session, because I think education and knowledge is power. I think it's really important. Engage with, speak with a physio if you can, if you've got a physio on site, because potentially pelvic floor exercises are the most effective thing you can do to improve incontinence outcomes and turn them into continent human beings. I know, obviously, people with dementia, it's going to be very difficult to do, but if you've got high functioning consumers, you could do a small group, which could be run by a physio, just to do some basic pelvic floor exercises. I mean, we can all do them, actually. We should all be doing them. As I've been getting ready for this continence education, I have to say I've been doing a lot more pelvic floor exercises than I usually do. And also walk around your environment, look at whether there is adequate signage, lighting. If people are using night lights at night for people who perhaps can toilet themselves at night, and is this on the care plan? Also look at rugs on floors and the general room layout. Take home tips for staff. When toileting people, allow them to sit on the toilet and give them time to empty their bladder. Often we're very rushed and we tend to put them on, take them off. Just give them that extra time to empty their bladder. Encourage independence with continence as well. Allow them to do as much with, wiping themselves, getting their pants down, etc., as much as they can themselves. Encourage a high fibre diet to avoid constipation. Monitor for constipation each shift, and really use your Bristol stool scale and really hand over to the RN if there's blanks or if you think somebody may be constipated. Ensure your clients are well hydrated. I think that's really important because it helps with your bowels for starters, and also try and ease off the drinks in the evening. I mean, obviously you're not going to say, right, no drinks after, you're not allowed to have another sip. Of course, people can have a sip, but certainly slowing down fluid intake after 6 or 7 o'clock does help with overnight, the number of times you have to void. People with cardiac failure, people with edematous legs, ankles, it really helps if you elevate their legs in the afternoon, because what will happen, rather than they've been, say, sitting up for most of the day, you pop them into bed, all of a sudden the fluid moves from the tissues into the major bloodstream and gets filtered by the kidneys, and there is definitely will be increased fluid into your bladder and resulting in potentially nocturia and increased urination overnight. So it's a really, really helpful thing to do. And if you can, avoid caffeine intake, you know, in the evenings, because that will irritate the bladder and cause increased urination overnight. So a summary of how do we know that we're doing well? If we have a good continence program with well-educated staff, then we will see the following. And of course, more importantly, a happy and confident consumer or resident. So you'll notice a reduction. These are all clinical indicators, so they should be being collected. So a reduction in UTIs, potentially a reduction in the episodes of delirium, a reduction in falls, a reduction in responsive behaviours, especially the ones that are related to wanting to use the toilet. That's why a really good incident form about looking at potential triggers can be very, very helpful in determining whether it is related to wanting to use the toilet. And also a reduction in continence costs. I always I always rang the provider and said, okay, what's the industry average for use for continence aids per day? And then I would have a look at what the facility I was at, what they were paying per day. And there was usually a discrepancy. So that's something that's well worth working on. So that really brings me to the end of my talk. I would like to say that have a look at these references. They are invaluable. I worked for the Continence Foundation of Australia for a contract job many years ago. They are an incredible resource. You can ring them up. There are always difficult, there are consumers that are difficult to try and work out a continence program for them. So ring up the continence helpline, ring up a provider to help you, your continence provider to help you with people that may, you're struggling to find a pattern. So use the resources, they're incredible and very, very helpful. So now we can get on to any questions, if there are any questions.
Thank you, Gabby. The chat has been very busy while you've been talking. What a great presentation. You can tell it's a hot topic and that you have got a passion for good continence care. So I'm going to run through the questions. Now we have the first one, which is that you can buy booster inserts, which are suggested for people on day outings to reduce the need to change during the day. Do you recommend these or no?
Look, if they work for an individual, fabulous.
Mm-hmm.
I'm just, yeah, that's not a problem at all. I just think when people are doing it to bulk up in case, I think that's when it's probably not a good idea to use. But yes, I think for outings, perfect.
I know what you're saying, Gabby, because I see that myself as well going around. Sometimes there's a large pad inside it and a wraparound pad, and it's more related to one thing, it's not working appropriately. It's not the appropriate continence aid for that person.
And it's
it's
uncomfortable to wear.
Yeah. Okay, the next one is, what are your thoughts around using bedside commodes for people who have urge incontinence and possible falls risks, either in home or in a residential facility, even with access to a toilet?
Again, this is my personal opinion. I think they're great. And they got taken out back in the day, back in my earlier days in aged care. We used to use them all the time. And I think if somebody can safely use the commode, I think they're very effective and I'm all for them.
Kath, can I jump in as the OT?
Yes,
I agree.
Yes, I can see you there.
I agree with Gabby on this. I think if the issue is around mobility and ability to get to the toilet in time, and you can assess that the person is able to safely use a commode, then they are a great tool.
Right. Thank you. Next one is, are there templates for continence screening form or care plan for clients in the community? Sorry, two questions. Are there templates for a continence screening form and care plan? And for clients in the community, how do you assess what aid is required?
There is, I'll answer just the first one again, Kath. Sorry, my mind just jumped then.
No, that's okay. Are there templates for continence screening and
there
care
are.
plan?
And if I jump back to the slide, the best practice, the Continence Foundation of Australia has a full suite of assessments. They've got the screening, they've got the 3-day bladder chart, they've got the bowel chart, they've got the care plan. It's all there online. So if you just jump onto the Continence Foundation of Australia website, you will find it.
Amazing.
And certainly if you can't, please just email Kath and I will send it out to you.
Thank you. And the second part was, how do you, if someone lives in the community, how do you assess what aid is required?
Oh, that's a good question. Personally, what I would do, you can ring up, you can ring up the Continence Foundation helpline. Because continence aids is such a competitive industry, they're each like tenner, depends, all of them will have helplines and you can ring them up and they will advise you on which is the best one to use.
Thank you. And one more, I think. Wondering if there's a threshold for a referral to allied health, so either physio, OT, speech dietitian, when there is a change in continence.
As in, I'm not too sure about that question.
When would you suggest that people refer?
Personally, I think what I would do, I would reassess them just in case, just to have another look. And if that doesn't work, again, look, it depends on really what's causing the incontinence. For example, if you think it's cognitive decline, potentially a referral to Dementia Australia, or for example, if you think it's it could be something like a prostate enlargement or whatever, refer it to your doctor. Yes, and if it's pelvic floor, which the majority of cases it is, potentially to a physio as well.
So it's really gathering all that information, like you're saying, Gaby, and assessing it.
And ringing the Continence helpline is incredibly helpful. I used to badger them relentlessly when I was first trying to understand this whole concept back when I started, literally, the first nursing home I walked into, people were sat with no underwear, with their dresses pulled up on drawer sheets, and that was continence management. I mean, so, you know, we know a lot more now, and there's a lot more products. So yeah, ring up the Continence helpline.
Amazing. Another question: Are continence aids indicated for incontinence management? And I think the answer to that is yes.
Yes, definitely.
Yeah. And one more, I think. Something that they've been considering is a scope for environmental modifications, such as a bidet for culturally sensitive toileting, and whether that could be accommodated in facilities alongside people and their families. Kate, you might have a thought on that. Yep, there you go.
Yeah, I've jumped in. So I've supported a lot of people in home who have their own bidets. I think plumbing is a particular issue unless the facility has been purposely designed to consider the option of bidets. I can look into it a little bit more, but I know that when we've addressed that sort of issue in the past, it has been plumbing that has been a bit of a limiting factor in health or aged care. Yep.
Something I've learnt new today. Thanks, Kate.
Yeah. But in terms of bidets, there's a lot of different things on the market. I mean, you can even get travel bidets. So if that's something that you want to go down, there's lots of kind of ways you can get around it if you've got a particular client who really is interested in a bidet.
Amazing. Thank you. What a great, I think that was our most popular chat that happened Gabby. So that is a wonderful way to head to your next slide, I think. And obviously, this is a topic that raises a lot of questions. And half an hour is just not long enough because we're already at 40 minutes with Gabby talking about good continence management. So we are running a masterclass with Gabby on the 16th of October, where she'll be going into a lot more detail about some of the things she touched on today. We will send you a link in the email after this with the slides and also a link to the recording, which you are more than welcome to share. And please do share with your teams. And we will also send you a link for feedback as well, because we love to hear from you about what you enjoyed and what you took out of today's session, and also other hot topics that you would like us to cover in the future. So again, thank you very much, Gabby, for today's session. Thank you, everyone, for coming along and for being so interactive.
Thank you. I really appreciate people taking the time to come and have a listen about continence not being
amazing.
a dirty.
Okay. Thank you, everyone. We will let you go 11 minutes late. Thank you very much for sticking around.
Thank you.